Hello, everyone. Thank you so for tuning in for another episode of Protecting the Vision. The National Optometric Foundation has a great webinar for you tonight and a fabulous guest speaker who's going to be sharing with us on the topic, My Head Hurts. Without further ado, I want to just tell you a little bit about the foundation. My name is Dr. Timothy Brown, Director of the Education Committee with the National Optometric Foundation. And as a part of the foundation, we try to support the NOA, our National Optometric Association, the parent company, the parent organization, in various ways. We're the financial arm for them. We try to support them as we just recently did in Columbus, Ohio, helping with eye exams to underserved communities. Wherever we travel for the NOA convention, we do serve where you go, and we get the opportunity to be able to give back to the community, help people get an eye exam, a complete eye exam, and also glasses. VSP so generously partner with us to make it happen for many people in that community to get their glasses, frames for free, and the lenses, prescription lenses in those frames also for free. We're able to help over 200 people in Columbus, Ohio this past weekend to get their eyes examined or to get glasses while we were there. Thanks to all of the docs who volunteered, the students who were there to help volunteer and help get these eye exams done. For our partners at VSP, we appreciate you for being there with us as well. And we are so grateful to have this opportunity. We try to also support students who are thinking about going to optometry school, maybe interested in becoming an optometrist, and those who are currently in optometry school. We try to support them as well. We try to do travel grants to help them to get to the NOA conference. We try to give out scholarships, and we're so thankful for those who give to allow us to continue to do the great things that we're doing in the community. We also try to help, along with the NOA, drive the initiative, the mission to educate communities about the three silent killers of your vision: diabetic retinopathy, hypertensive retinopathy, and also glaucoma. We also try to work with leaders that's out in various communities to support them as they try to educate and provide resources to the people in their community as well. We would love to continue to do these webinars. We have different speakers on each Monday, the third Monday of each month at 7 o'clock as free public information for you and your family. Please feel free to share these webinars. You can go on our YouTube channel where you can see our previous webinars that we've done over the past 3 years, and you can look at those and you can share them with your family and friends, your colleagues. We also are on Facebook, so if you want to go to our Facebook page, we welcome you there to like our Facebook page and follow us there. We also have a website, www.nationaloptometricfoundation.com, where you can find more about us and the things that we do. See some photos on there as well. We'll be updating the website with the photos that we just gathered from the convention in Columbus, Ohio. And also, if you would like to give, even if it's just $10, $20, we have a cash out where you can give tonight. You just go and do your gift at $ Protecting the Vision, and we'll get that through our cash out. We thank you in advance. Thank you so much. I am excited to have with us tonight a great guest speaker, very fine gentleman, Dr. Britton Adams. He's been practicing in Dallas since August of 2024. He's a native of Oklahoma, which he completed his undergrad at the University of Central Oklahoma, and then he went to obtain his optometry degree at Northeastern State College of Optometry in Oklahoma in 2018. Dr. Adams' favorite part about being an optometrist is the relationship he establishes with his patients year after year, and just learning more about them outside of the normal, which is better, 1 or 2. Not when he's not at work, Dr. Adams, he's involved with his church. He enjoys spending time with his family, including his dog, Hope. And he's actively pursuing his dream of acting. All right, Dr. Adams, that's an amazing bio that you have here. We're so excited and thrilled to have you on the show. Welcome to Protecting the Vision, where we're going to talk about my head hurts. Welcome to the show, Dr. Adams.
Awesome. Thank you for having me. Thank you so much, man. Appreciate it. It's nice to reconnect. It's been a couple of years since I've seen you in person. I think the last convention I was at was probably in 2019. So it's overdue for me to come out and see you guys. But yeah, thank you for having me.
We're so excited to have you as one of our guest speakers on the webinar. Thank you for saying yes to just
Yes, sir.
sharing wisdom, letting the public know a little bit about this topic and some of the things that we're going to dive into tonight. I know you got a great lineup ready to share, and it's going to be an exciting opportunity. So I may just go find my favorite drink and sit back and relax as well. But no, I'll be here. We'll have a conversation.
Yeah,
We're
don't
going
you
to
do
talk.
that.
Go get some popcorn because I know this is going to be dynamic information. And talking about you being a native of Oklahoma, we had a silent auction at the NOA conference in Columbus, Ohio. And
Mhm.
behind me is one of the art pieces that I was able to bring home. I was able to win that bid. That is Black Wall Street,
Yes, sir.
Greenwood, Oklahoma. Yeah, Black Wall Street there. And they try to bid against me, but
Yeah.
overall I won. So
I'm glad you
happy
great
to
people
bring that.
always.
And then
Yeah.
yes, and then Tupac back there as well. My wife wanted that one, so that's another piece that's back there as well. There, so so much great artwork that was on display at
Yeah.
the NOA conference, and I'm so glad that we got a chance to participate in that silent auction. So I just wanted to mention that for those who could not make it,
Yeah.
we hope that you can make it next year. We are planning to be in St. Louis, Missouri.
The only other thing you need beside all that artwork is an Oklahoma City Thunder banner, considering you're the champ. You're the champ.
that would be that would be the icing on the cake,
Mighty
right?
icing on the cake, man. Icing on the cake.
Hey, we may have to work on that. They did play very well, so we may have to work on that one
Yes,
there. That's
sir.
good.
Yes, sir.
Now, you're sharing with us about people. Sometimes they come into the office. They're talking about, my head hurts, and we don't know. They're talking about they have a headache. Even we had some people in the office today, that was saying that. But what do you find as common eye-related causes for headaches? Because we know that there's a long list
Right.
of reasons that people can have headaches, and we try to tell them that when they come into the office there. And sometimes their doctor, the neurologist, they'll send them to an optometrist and to
Mhm.
help them rule out, is
Yeah.
there anything eye related that's causing these headaches? So, with your practice and in your getting about and your education, what have you seen as the common causes for headaches eye related?
Well, the most common causes are the fact that they need some glasses or contacts. They need some correction, something refractive. So they could have hyperopia, which is also called farsightedness. We see this a lot of individuals, especially young kids. They come and that's the first thing that their parents are kind to rule out is that they're coming home or having headaches on a daily basis. And so they'll come and we find out they have a little bit of prescription that will prescribe, for reading because they're doing a lot of prolonged mirror work, right? So everybody, I can be doing an exam and then look behind me and the other two kids are on iPads. We're always here, right? So it could be correct. They need some type of correction. They have a little bit of astigmatism, Astigmatism is where the cornea is shaped more like a football than a basketball, so light doesn't enter like it needs to. Or, they could be a little bit nearsighted, so just trouble seeing far away. All of those can cause some frontal headaches and towards the frontal. And then you have the less common, which are, anything from ruling out from, worst case scenario, a tumor, an aneurysm, idiopathic intracranial hypertension or swelling of the optic nerve in the back, which I'll touch on some of that later. And then you also have another issue is dry eyes. If your eyes are dry, surprisingly, you can get a little bit of eye strain and headaches along with that. So yes, But the most common are
Wow.
going to be your regular farsightedness, nearsightedness, and astigmatism.
And, and I get that. Farsightedness, nearsightedness, myopia, hyperopia, or astigmatism. Those are some common reasons why people come to the optometrist complaining that their head is hurted. But I
Mm-hmm.
also caught that you mentioned some things that sounded pretty serious.
Yes.
You mentioned that other conditions can cause people to come in and say, hey, my head hurts. And it may not just be that they need contacts or glasses there.
Mm-hmm.
I do want you to speak about that because I want to know how an optometrist, patients, if you're listening, how your eye doctor can tell the difference between needing a refractive error corrected, with glasses or contacts versus, hey, this person could have optic neuritis, that's causing their head to hurt that way. Can
Yes.
you speak a little bit about that for us, Doc?
Yes, sir. A lot of times it's going to be the test. So, we'll always start with the refraction to see if they have some prescription there. And before I move on to the worst case scenario, I will also tell the patients that are in here to make sure that, your optometrist is dilating, especially your kids' eyes, at times, because a lot of times kids can overfocus during an eye exam. And so what they need is, you don't want to say that they get in a prescription when it's still going to cause the same issue. A lot of times the optometrist will know though, right? But it's always great to have them have their eyes dilated, especially young kids, with a drop is called cyclopentolate. That's going to dilate their eyes and for about good 12 to 24 hours. And they're up close is going to be a little bit hard to see for a couple of hours, but it's going to make sure their prescription is accurate, because we would hate for them to come out of some with a prescription that's not what they need to be, and they're going to still have problems, right? So that's a first great test, along with flipping between 1 and 2 to figure out if it's something prescription wise. Now, for other things that we would do as far as testing are, we may do a visual field. A lot of times when they're having headaches, there's something in the back of the eye, such as optic neuritis, they'll have a little bit of visual field problems, right? So they can't see up here or toward the side. And so a lot of offices will have a visual field test to actually do that. So they'll cover up one eye, have you stare at a central dot as light flash around you, right? And they'll do each eye individually. And if that's showing some defects, then it can lead us to exactly what the problem may be. Other tests that they can do is what is called testing your color vision. And specific optic neuritis, which is inflammation of the optic nerve in the back of the eye, there is a little bit of desaturation or fading of colors, right? So one thing that I would do is I would say, okay, if you're having pain or headaches, specifically on one eye, like the right eye, I would say, okay, look at this. I'll hold up something red, right? Like the top of, I'm sure you guys have all seen this. Whenever you get dilated, they'll have the top of the cap will be red. I also have them, I say, okay, if this is 100% versus if their right eye, still with me? Okay, there we go. If the right eye, and I'll say, okay, is this like 100% red? And they're like, yeah, that's super. And then I'll turn over to the other eye, and I'm like, okay, how red is it now? Is it about half of that? And they're like, yeah, it's not as red as before. Then that could be an issue that points to optic neuritis. Dr. Brown, you still there? Don't leave me here all alone. No, I'm just kidding. Okay, there we go. So we would do that. Other thing that we would do is just we will see, okay, is there some vision loss? All right. So a lot of times if it's refractive, astigmatism, farsightedness, things like that, there's not going to be as much of a vision loss. There'll be some blur and you'll have some headaches, but with more severe conditions, you'll have what is called transient vision loss, where your vision loss will, for a short term, will go in and out, right? And then maybe come back. So those are other things that we could do. And then, of course, we want to dilate you more than anything. So dilate you or take pictures to kind of see how the optic, to see how the optic nerve looks in the back. The optic nerve connects your brain, is a connection between your eyes and your brain, okay? And so if it is inflamed, then there could be some serious issues going back there, which will then either do some other test work or refer out to see what's going on. I'll also, Dr. Brown, you still there? I feel like we're Losing you.
I am here. I'm still here. I'm still here.
Okay. A lot of times with there you go. A lot of times with refractive, so myopia and all that, you're having little frontal headaches. Sometimes if it's more severe, you can sometimes even get off like pain off to the side, get some throbbing headache. You can get what is called a cluster headache. That's something very common in Horner syndrome. I'll touch on that later. But it's like just excruciating pain, especially around one eye. And then you can also get where, like I said before, where it's a headache off to the side, and with patients a lot when they're like brushing their hair or combing their hair, and it's called giant cell arteritis, which can lead to another form of inflammation in the back of the eye as well. So I'll touch on all those a little bit later, but to answer your original question, those are some of the main diagnostic tools that would help us determine if it's refractive or something more serious.
Well, Doc, you definitely gave some wisdom there. You dropped a lot of golden nuggets. I hope that those who are listening can understand why we ask so many questions when it comes to your history, why we like to follow up when you tell us certain things about experiences that you've had, vision related or health wise. It's not that we're nosy. Your optometrist can detect things during an eye exam that can alert your primary care doctor and get further testing done, blood work done, do the things that's necessary to help the doctor manage and treat not only just eye diseases, but systemic. There are things that can be detected systemic, and they can alert your primary care doctor about that as well. Dr. Adams laid out some great information to let you know about the things that can be checked there. He's going to go in more details, but Dr. Adams, there's something like idiopathic intracranial hypertension. I guess you could break that down, for our audience there, but sometimes things like that shows up during an eye exam. And I'm wondering, you as an optometrist can maybe tell the audience the things that you're looking for, and maybe if there's an optometrist listening, the things that they could be looking for during an eye exam when it comes to something like that.
Yeah. So again, you're going to have some headaches, some vision loss that can go out in short periods of time, as well as you can have a visual field defect that's an enlarged blind spot. So we all have a blind spot. And sometimes that blind spot can be enlarged if a person has idiopathic intracranial hypertension. So what this is, the other name for it is called pseudotumor cerebri. It's whenever we look in the back of the eye, the optic nerve, we want it to be nice and round and get very smooth. The color is good, but if we were to look back there and we start to see it looks inflamed, you can definitely tell. It just doesn't look like normal. Okay. And I'm actually going to show you guys a picture because I have a case study on a patient that I saw a few months ago that had this. And so I'll show you a picture of what a normal optic nerve looks like versus one that has a patient that has IIH. But this patient could come in. Yeah, perfect. Thank you. I'll go ahead and put it up now. So you'll have the IIH. If you look over, it's maybe kind of hard to tell. Actually, let's go ahead and take this down for 1 second for me, okay? So sorry about that. But yeah, when a person has IH, they'll also come in complaining of maybe some nausea, some tinnitus, which is basically ringing in the ears and whatnot. And this patient, what's going on is we all have cerebrospinal fluid that protects our brain, our spinal cord, okay? So with this, a patient, it's elevated, cerebrospinal fluid. Now, the composition is normal. So there's different proteins that develop this cerebrospinal fluid. The components of it is normal. It's just, it's still elevated, right? It's higher than it needs to be. And so what it does, it puts pressure on that optic nerve, right? And so that's where the headaches come from. A lot of issues. We see this in a lot of women, more than men, people that may be a little bit more overweight, high body mass index over like probably 30 or so. Patients will come in saying that their headaches also are worse, like if they were lying down. That can be another thing that they will tell you. And then you may also want to ask about new medication there was my patient that I'm going to talk to you guys later about was on, she was on a medication for schizophrenia and bipolar. And so that has actually could be a possible connection for why she came in with that problem. But the main thing is, like I said, we want to dilate, and then we look back there, and then what happens is, well, I'll talk about the treatment and everything once I talk about the patient later. I think we'll have some, that way you guys can see what I'm talking about.
But your role as an optometrist is very important. And see, a lot of people think that when they come to the optometrist, it's one or two.
Right.
Here's a pair of glasses, you know, you're out the door. But you have a very important role as an optometrist, identifying disorders and diseases and being able to distinguish, you know, between the two, you know, like saying papilledema versus pseudopapilledema, you know, it's important for you as an optometrist to distinguish between the two, you know, and your role that you play in everything. I don't know if you want to add anything on top of that.
Yeah, so true papilledema, you're going to have some of the same issues with the idiopathic intracranial hypertension, the IAH. However, with true papilledema, it could be something like that's causing vision loss, like a tumor compressed on the optic nerve. A patient that comes in with very high blood pressure, the worst stage, they can get some papilledema where and papilledema, every time I say it, remember, it's just elevation of the optic nerve, okay? So they can have the high blood pressure, and we don't want that to, you know, get worse. We don't want any cases of stroke or aneurysm. And so you'll also have a lot more bleeding in the back of the eye with true papilledema. And then unlike IIH, the composition of the cerebrospinal fluid, so remember the proteins that develop and make up that cerebrospinal fluid, are actually high as well, right? And so one of the things that you want to make sure with both IIH and true papilledema is you want to make sure that you're going to refer, right? And one thing that the doctor that you refer to, whether emergency room, the PCP, whatever, the first thing that they should do is make sure that they are doing what is called, they're doing an MRI first, okay? Because a lot of times in IAH, they'll do a lumbar puncture to help a lumbar puncture, which is, you know, basically relieving some of that cerebrospinal fluid, which will help out relieve those headaches as well. But patients that, if they do that before they do an MRI, and say if it's true papilledema, so something is compressing against that optic nerve, if they do that before the MRI, then they can develop what is called a brain herniation, which is where their brain actually falls onto their brainstem, and that's not good, right? So the first thing that they need to do before they do any type of lumbar puncture is an MRI to see, okay, to rule out, is there a mass, is there a tumor, is there an aneurysm, is there something more worse than IIH, right? Now, that was differentiating IIH versus true papilledema. Now, true papilledema versus pseudopapilledema, which another form of pseudopapilledema is called drusen. So if you look back in the optic nerve, and there are a lot of them, will be calcium deposits, so high yellow deposits around the optic nerve. And what happens is, this is not actually as scary as it sounds, right? Now it's very rare. You know, you have like 4% of the population may develop this. A lot of times in kids, it's a little bit more buried, but it's more noticeable in adults. But we see this all the time, right? And so one thing that I do is I do an OCT, which is basically, it's kind of like an X-ray, but we're scanning that optic nerve, right? And so whenever we scan that optic nerve, there's certain signs that's going to say, okay, is this true papilledema or is this just drusen, right? And so drusen around the optic nerve can have some you can get some headaches as well. But we will also rule out with the OCT. We will do other testing just to see, okay, is this just drusen? If so, then we're good to go. A lot of times, if there are vision loss, there's really nothing that can be done about it. But in my 7 years of practicing, I really haven't seen a whole lot of drusen around the optic nerve or pseudopapilledema, you know, interchangeable. I haven't really seen a whole lot that has caused a substantial vision loss or issues like true papilledema. So did I answer your question, Dr. Brown?
You did, and one of the great things that I wanted to just draw attention to is that you use the word refer. You were not afraid to refer you out to a
Mhm,
specialist or to someone else, who need to take care of you as a
mhm,
patient there. Your optometrist is helping to manage. They may diagnose some things.
mhm,
They may be a little suspicious about some things, but referring you out is the key point that some of the
mhm,
optometrists make day in and day out that allow you to get better care and
mhm,
better testing done to
mhm.
confirm what they may be suspicious about as well. So I
Right,
say that to say this, that we work hand in hand with your other doctors.
exactly. We're the first line of defense,
So
really.
the information that you provide is important. So when you go to your right, it's important to give your a good medical history.
Yes, sir. Yes, sir.
So,
Um,
Dr. Adams, can you hear me?
yeah, I can hear you. We're back. Yeah, we're going to be the first
Okay.
line of
Yeah.
defense.
So I just wanted to stress the importance.
Hmm. Yeah, it's really important. It's really important. I mean, if there's anything that I'm questioning, we use the word punt, and I'm going to punt it out. So we're going to refer it out just because, we've noticed something's not normal, and so we're going to send you to the specialist that's going to do further testing and have the treatments and everything to give you a better answer to what's going on as well. So yeah.
Right. And some patients, we also check in our office, Dr. Adams. I know we're talking about my head hurts, and I know you got some things that you're going to show regarding to that. But we also try to check to make sure their eyes are working together as a team, binocular
Right.
vision. And sometimes you have binocular vision disorders, that happens, and they can lead to chronic diseases or and chronic disorders there as well. Can you talk a little bit about that when it comes to seeing that in your office there, binocular vision disorders, how you will manage that, and diagnose those things as well?
Yes, sir. Yes, sir. So one of the most common reasons for headaches, especially with near work, was what is called convergence insufficiency. So basically, it's when our alignment of our eyes are not aligned appropriately. Okay. So a lot of times, as optometrists, we'll do what is called a cover test. We'll put a paddle in your eyes and go from one eye to the other. And as we're covering one eye, that eye will go to like a natural resting position. And as it moves over to the other eye, so for instance, exophoria is whenever the natural position of your eye is out. It's not really noticeable because a lot of times when we're staring at things, people think we're staring, and the alignment's the same. But if I were to have that eye covered, it may go out a little bit. And as I'm going to the other eye, it comes back in. So we do testing for cover test. And other testing behind the phoropter, which is the instrument we use to, check your vision. And what happens is if there are certain numbers that don't line up, or we do a test where we're bringing something close to you, and if you're like, if I'm bringing having you stare at a letter on a paddle, and I'm bringing it close to your eyes, and it starts to get blurry way out here, or if you're starting to see double, we don't want that. Or if you're having any pain, we don't want that. We want you to be able to come as close to your nose as possible, converging, bring your eyes together so that you can, until you have to say that, okay, now I see double, right? And so we do that measurement a couple of times as well. And so if we notice that there are some signs of what is called convergence insufficiency, we see this a lot, of course, in kids too. And so a lot of times what's going to help them out more than anything is vision therapy. Because it's a binocular issue. The eyes aren't working together as a team to do what they need to do, And so vision therapy, ideally research say up until about the age of, I'll probably say 10, 9 or 10, maybe a little bit more, vision therapy can be a big benefit. But I've had adults that have had success with vision therapy as well. So it's not one glove fits all. It's just, as far as what research has normally proven. But basically, they'll go to vision therapy and they'll work with a vision therapist who specializes in this, and they'll have them on weeks. It could be 12 weeks, maybe longer, but normally around 12 or so is whenever they're doing exercise with them to help their eyes work together as a team. So one thing they'll do is it's pretty cool. It's called a Brock string. You can actually, probably order this on Amazon as well. But what it is, it's a string with 3 separate colors on it. I think it's like green, yellow, and red. Three separate balls, right? And so as they're pulling, they're staying about 2 feet away or whatnot, and then you're having your child stare at one bead. And what they should see is, I know this is probably way more than you guys asked for, but they should see a cross in front and then a cross further back. And what they're doing is they're trying to make sure that they're able to converge the strings right into where that bead is. And then they'll go to different levels, right? So again, this is all stuff that your vision therapist is going to go over with you and your child. Another thing that you can do is just a pencil push-up. You just take a regular pencil or pen and you just practice at home, having them come up to their face until they see double, and doing that a couple of times, So there's been more proven success with, of course, the in-office therapies than just doing that alone with a pencil push-up. But if you were to take your child, if your optometrist has noticed that there's issues with those things, then they can refer to a vision therapist that specializes. Prism is another thing. Prism helps shift your eyes to where the image is. They can put Prism in your glasses. A lot of times that's more so for adults. Maybe they've had a little bit of trauma or whatnot. And then I don't know if you do this as well, Dr. Brown, but I haven't had the experience with it yet, but the neuro lens, it's another thing it's another type of lens that comes with Prism in it to help those with convergence insufficiency or other binocular issues like that. So, yeah.
Yeah. It's great that you mentioned vision therapy. Not everybody will be doing vision therapy, but it is done at Insight Family Eye Care. We do it in Augusta. Dr. Brown, Sharita Brown, she's great working with children and adults with vision therapy when their eyes are not working together as a team. One eye is doing all the work while the other eye is either hanging in or hanging out. Vision therapy has been great for so many people, so many success stories after their 12 or 26 weeks of vision therapy, or maybe just 8 sessions. It depends on what the issue is, and then what program we can come up with there to help the patient there, or what program Dr. Brown comes up with there to help the patient. And they come back each week doing it. She always tell the patient, vision therapy is like physical therapy for the eyes, and you have to keep working it, you see improvement over time there. So great. Glad that you mentioned that. This webinar is here to explore and to mention things that we probably haven't talked about on our previous webinars, and you're hitting a lot of areas that we haven't discussed on the webinar. So again, Dr. Adams, thank you for saying yes to being our guest speaker tonight with us there. And I know that the best is yet to come. This is just halfway, and you got a lot more to unpack. Speaking of that, I've had a lot of guest speakers on the webinar talking about dry eyes. And after talking to you and reading about some of the things that you've presented, I've learned that dry eye can be related to headaches as well.
Yes, sir.
And I just wanted you to talk about that, because I know a lot of people watching, or they may catch this webinar later, and they've been facing dry eyes, or they know someone who's been facing dry eye issues, and they've also been having headaches. So can you talk a little bit about that for our audience today?
Yes, sir. Yeah. So a lot of things that dry eye can mimic are, you can think of something worse, but it's actually that your eyes are dry. So if there's any burning, stinging, you're getting a lot of eye fatigue. We are constantly at the computer. I talk to patients that are working 8 to 10 hours at the computer alone. We're living here in Texas. My eyes are bad. I'm on medication that makes my eyes dry. Claritin, Zyrtec, all those are certain medications that dry your eyes. They dry your whole body out. They dry your eyes out too. I remember when I was on help me out, Dr. Brown, acne. What was it? Let's start with
what are we
start with it's P. So it starts with a P. Whenever somebody's on acne as a kid,
I know, and it can't
slip my mind. But yeah. Anyway, I was on that medication, and to help out with my acne. And goodness, it's gonna slip my mind. But it was drying my entire system out, my lips and my eyes and everything. But a lot of times we think that that it's our head, it's like our headache. It mimics a headache, because our eyes, our tear film, which is surrounds our cornea. Our cornea is the window of the eye. And so we want a stable tear film, it's like we want to be able to see. So if you're looking at something, your vision's going in and out, you're getting eye fatigue. Proactive. Thank you, sir. I appreciate that. So I think that if we're staring at the computer a lot and you're getting that eye strain, it's almost like we're like, man, I'm getting a headache, but my eyes are just really dry. And so I tell patients all the time a 20-20-20 rule. Okay. Every 20 minutes, take a 20-second break, look 20 feet out, take a walk outside, look out the window, just relax your eyes. We don't realize how much we're not blinking while we're at the computer. Our eyes are getting more and more dry and we're getting headaches by the end of the day. And it's not because we're not wearing our glasses. It's not because we need a prescription. Our eyes are just dry and they're causing those headaches. So if you have some lubricating drops, I know nobody likes drops, but you got to do them. Okay. So, and it's not, and if you go to our optometrist, and optometrist say, hey, you need to do this 3 to 4 times a day. Doing it one time and then come back for a follow-up and being like, hey, it didn't really work. And they ask you, did you do it 3 or 4 times a day? You said, no, like once, probably, it's not going to work, right? Or you didn't give it the time, or you didn't do what the instructions said. Don't treat over-the-counter artificial tears any less than you would treat your medication that's actually prescribed. So if your primary care doctor said, hey, you need to take this antibiotic twice a day for 10 days, even if you start to feel better, you take it for 10 days, you're probably going to do it. Do the same thing. We give you recommendations for over-the-counter artificial tears. That's my starting point, just because as far as cost efficiency, it's easier as well. But there's so many artificial tears out there that have different ingredients. A lot of them are preservative-free as well, but they're going to help, but you've got to do your due diligence and actually put them in your eyes, right? And then if you're not having if you're not doing any better on that, then your optometrist can go up the next levels to other things, prescription and things like that. But just I want to just leave you with this: do what they say as far as the amount of time, the frequency, and the dosage and all that.
Yeah, so you draw a great point. Patients, we send you home, say, hey, take this many times, and you're only been doing it this one, or you stop doing it because you felt better, and then you get this problem again, and you come back in the office and it's not working. So is it not working, or you're not following the directions that the doctor gave? So it's important to follow the directions that the doctor gave you for the meds all the way through. And if you have any questions about it, pick up the phone and call them. I always talk about it on the webinar. Keep the line of communication open between you and your doctor, because we're doing our best to help take care of you and 10, 20 other patients out there. So your doctor need to know if you're not following the directions that they gave you when it comes to treatment as well there too. So I'm glad you brought that up, Dr. Adams, because that's important for follow-up care. So some patients may come in your office there and they're talking about they have, it feels like a headache that's on one side, unilateral there, if that happens there too. What could be some of the reason? If they say they have eye pain, what's some of the conditions that they could be experiencing when it comes from that?
As I mentioned earlier, we're thinking about giant cell arteritis, which is basically inflammation of certain arteries, medium and large size arteries that supply your face and your neck. A lot of patients will also complain of jaw claudication, which is basically having trouble chewing. They're having chewing issues that hurts when they chew. And then, of course, if they're like brushing their hair, then it really hurts as well. A lot of these patients are 50 to 55 or older. Some of them are even older than that, but you're not really going to find this in a lot of younger patients. And they will also come in with vision loss that can sometimes go over to the other eye if it's not caught in time. Now, unfortunately, a lot of the vision loss that they experience is hard to gain. You really can't recover. But if we catch it and we send them for the appropriate testing, and that then, you know, it can prevent them from going to the other eye. Now, a lot of times these patients, we will send them for labs as well. So labs we'll send them for 2 types of labs, just to kind of make sure that it's inflammation, something going on. But the very first thing we do before we do any of that, of course, like we just mentioned multiple times, is we will dilate your eyes, take pictures to make sure that optic nerve looks like we expect it to look for this. And then also the patients may complain of a visual field defect. So altitudinal, which means they'll complain up here, you know, down here. And then also we would most likely start them on oral steroids. If we're already thinking that this could be GCA. Now, when I say GCA, giant cell arteritis is the most common cause of AION. So I don't want y'all to get that confused. GCA is the condition, but also AION is what we see. So we see anterior ischemic optic neuropathy, basically. And so what we see when we see the optic nerve is like, man, we see it's inflamed. And what happens is some of the arteries going to the optic nerve causes that inflammation. And of course, there's the vision loss that follows. So we will get you started on steroids, going back to what I was talking about. Get you started on steroids, even if we're thinking that, hey, this could be what it is. We'll start you on a round. And then, of course, we'll send you to the specialist. And what they're most likely going to do is a carotid dissection. It's a temporal artery dissection of that temporal artery. And that's normally the baseline that they're going to, the mainstay of treatment that they're going to do. But of course, we'll start you on the steroids. Now, yeah, AION. Wow. Sorry, go ahead.
No, Doc, I'm just saying you're unpacking some really deep information. This is really good. I mean, I could see the NOA calling you to be a guest speaker at the conference one year. Yeah, so you just have your card ready. I said it here first. If you're watching this, NOA, this guy is going to be ready to speak to you.
I did want to touch on, that was good. Also, another thing that could cause vision loss, specifically to one eye, more so to the side, you'll get like this throbbing migraine, is what I'm sure we all heard of glaucoma. Most glaucoma, you know, is treated with drops. People have known they have glaucoma. Normally it's not a lot of pain going on. But if a patient's eye pressure gets above 40, 45, they're going to notice a lot of pain, a lot of pressure, and a lot of headaches, throbbing headaches. They'll have a lot of light sensitivity. What happens is fluid is not flowing like it needs to. So we have this fluid that develops in our eyes, and whenever it is clogged up, kind of like a drainage system, that creates a high eye pressure. Okay, so if you have parents, grandparents that say, hey, I need to go in and get my pressure. How's your pressure, your eye pressure? They want to get it checked to make sure that, because that's how we control, that's how we treat it. We help treat it by making sure that eye pressure stays where we need it to be. Well, say if they have have trauma, you know, have something, they get a ball to the eye and it hits the eye, but then they notice that that they begin to have these headaches and whatnot. Well, their angles may have narrowed where that fluid not able to flow like it needs to, and that creates a high eye pressure. So the doctor will come in, and then where I used to practice, we were able to actually help open that up with a laser. Here, I'm not able to, different laws, but we would still refer to a glaucoma specialist that can, what they'll do is they will put I know this is too much information, I'm so sorry. They will put a hole in your iris, which is the color part of your eye, to help it serve as another passage for that fluid to flow. So therefore that eye pressure can be relieved, and there you're not experiencing that anymore. And then they'll probably put you on drops as well. But that's another thing that can cause some pain or throbbing on the side. And then last one is there's one more I want to talk about. Oh, optic neuritis, which we touched on that briefly earlier, but multiple sclerosis, if you guys heard of that, that is the most common cause of optic neuritis, which is inflammation in the back of the eye. Normally it's one eye, and you get a lot of pain with eye movement. So if you look, you're getting a lot of pain every time you move your eyes. So patients may come in complaining of that. They may come in complaining of what is called a central scotoma, or basically the central part of their vision is very dim, or hard to see, but they can see the peripheral around it. And they also might complain of, again, we're going to the color distinction, right? So the color vision is a little bit unequal. So things are a little bit more faded on the eye that they're experiencing that. And then, but yeah, we see this a lot in patients who have MS. You'll get these, a lot of women have multiple sclerosis. It's just an autoimmune issue that attacks certain coverings of the back of the eye, or certain nerve cells, I should say. So yeah. Okay, I think that's
great hit there. I mean, again, you're impacting a lot of great information, and I know you feel like you're going over and beyond, but it's helping someone. I guarantee you that. And they can always catch the replay there too. You can listen to this over and over and over. You know, can't sleep at night, go get this webinar, listen to Dr. Adams talk to you about my head hurt. This is an important topic, very important topic. And sometimes people come into their optometrist office, Dr. Adams, and they're dealing with migraines, you know, and they're like, man, I got a cure headache. It's really hurting me, sensitive to light and everything like that. How do you go about managing those types of patients as well when they come in complain about it? It might be seeing color in their vision, things of that sort.
Yeah. So first, I'll make sure it's nothing like I talked about before, where it's glaucoma, a narrow angle glaucoma. So I would, put a lens on their eye and making sure that that angle's open, as well as check their eye pressure first, right? Just because we want to make sure that's not what the issue is. But a lot of times patients will come in complaining of, like, they'll see lights, and they'll also see maybe some like zigzag vision, like kaleidoscope images. And so what we call that is a classic migraine, right? So we will first dilate them and take photos to make sure that it's nothing worse. Retinal detachment, make sure there's no tear in their eye. Those are the things that can really impact our vision and cause them to be lost permanently. But if they're complaining of saying, okay, kind of, I'm seeing this stuff, I saw some craziness, my vision may have went in and out for a couple of minutes, or maybe even up to 30 minutes, right? And then they're having the headache that follows. That can be a classic migraine. Now, the only difference between a classic and an ocular migraine is they don't really have too much of headaches that follow, okay? But you will still kind of get some of the same visual effects. Or if you ever heard of aura, that's another thing. Whenever you're seeing things that's not really supposed to be there, that's aura. So you can get a migraine with aura, which is most common, or ocular migraine without aura, right? And so we just want to put you at ease. So a patient comes in complaining of those things, I would say, I'll dilate them, check the back of the eye, let them know. And then I will also see if there's any changes in their lifestyle. It could be that they're not getting enough sleep. Could be some food issues. I read that chocolate, wine, and I even think cheese are certain things in the dietary changes that can bring about these. A lot of times we see this more in women due to, hormonal changes and whatnot. So I just tell them, I just kind of ask them those questions. Hey, are you stressed? Are you getting enough sleep? Just so we can tackle that issue and give them comfort knowing that nothing is going on in the back of the eye. Their optic nerve looks good. It's not a detachment. All that is great. Go home, get some sleep, take a vacation, eat some salad, whatever. But those are some things that we would kind of talk to them about. And then I'm going to say one more thing. Yeah, I think that's about it.
Well, you got me when you started talking about chocolate, wine, and cheese.
Right.
You have to be
And
careful.
I basically tell patients that something's happened where, their vessels in the back of the eye are sporadically kind of spasming out back there. It's like they don't know what they're doing, which are contributing to the visual changes that they're experiencing, as well as the headaches. So, but yeah. But yeah, man, that chocolate,
Wow.
I love that chocolate.
That's the one, man. I had
Yeah.
some chocolate today, so I'm like, man. So as we get near the end, there may be some things that you want to show, so you can just let us know, and we can bring those to the screen. But one of my last questions that I wanted to ask you was to talk about some of the red flags, the symptoms that may indicate eye-related headaches there. So just getting back to as you've been doing, talking about my head hurts there.
Mhm.
Eye-related headache that's more part of an urgent, or emergent condition there for us. They're requiring that we send them immediately. You talked about referring out to a specialist. Some things make it hold for a few days or a week, but there are some things that need immediate referral there. And I just wanted you to touch upon that before you leave us tonight.
For sure, for sure. So sudden vision loss, as we talked about earlier with the patient with the GCA, giant cell arteritis, they get a new headache and they're over the age of 50, 60, and that's something that we want to make sure we refer out immediately after we've taken a look at the back of the eye. Swelling in the back of the eye, so looking in the back and seeing the optic nerve swell or edematous, in fact, that shows us inflammation. Also, pupil. I didn't touch on this. So a lot of times with patients with like multiple sclerosis or optic neuritis, we want to look at their pupils. APD, afferent pupillary defect, is whenever we shine. If I were to shine a light in one eye, we want to make sure it gets smaller, right? It constricts, and then whenever we take it away, it's supposed to get bigger. But if we were to shine the light in this eye and it doesn't constrict appropriately, or also if we were to shine a light in this eye, the other eye is supposed to constrict as well. And so if it's not
Right.
doing that, we would do what is called like a quick flashlight test. And then if we see anything out of the ordinary, then that tells us, okay, that something's going on neurologically. And you've all watched movies where that's one of the first things that they're doing. Like they're put patients' eyes open, shining a light to see, okay, what's going on. It could be a tumor, it could be aneurysm, it could be something worse, right? And then I know this is, I really wanted to touch on this because it's so unique, but another one that you might want to refer to, we talked about GCA, we talked about optic neuritis, we talked about all of that, right? Papilledema, Horner syndrome. I briefly mentioned that earlier. Horner syndrome is another type of condition where you can get some headaches. It's called a cluster headache. Really, really, especially it's like penetrating around one eye. And then what you would see, three things that you would see, that we see, is what is called a ptosis. Basically, that's where their eyelid is drooped down a little bit, and it's unequal to the other eye. We will see meiosis, which is basically constriction of the pupil, and then we will see anhidrosis. Basically, that one side of their face it's not sweating; it's a lack of sweating. So ideally, what's happening is there's a certain along the pathway. There's a sympathetic nerve system. There's something going along, and there's a lesion, or there's a certain area that's affected. And so ideally, our sympathetic nervous system is like our fight or flight, right? So whenever we're scared, or whenever we're in dark light, or something's going on, our pupils have a tendency to dilate, right? And so if something is attacking that sympathetic nerve pathway, what happens is, okay, that our pupil is not dilating. So what we get is constriction. And then we also get other issues such as the droopy eyelid. And so depending on, that's another thing that we're going to refer automatically. Hey, I don't have the instrumentation or the tools to see what's going on. And so we'll send them out where they'll get an MRI to make sure it's not a stroke, or make sure it's not anything like that, or MS, and then they'll also make sure that it's nothing going on like a tumor. You can get what is called a Pancoast tumor, which is in the neck. And so all of these are things that, again, we don't have this stuff in our office. I'm not the one that went to med school to know about it. I learned about it, but I'm not going to have the instrumentation and all that to do. So we're going to see that stuff. We're going to identify those three signs: ptosis, anhidrosis, meiosis, and say, hey, this looks like Horner syndrome, and you have a headache around your eye like that. Let's go ahead and punch you out to the specialist. So,
yeah. Yep. You send out to a specialist for better management, care, treatment, whatever they have to do for safety of that patient there. You touch upon a great one, man. Brings back just sitting in class there, Dr. Lombardi, at PCO.
Right.
Just great information there as you're talking there. Are there any photos that you want to show our listening audience
Yes,
that you
sir.
want us to put up for you?
Yeah,
Charts.
yeah, we'll go ahead and do that. That case presentation, we'll start with that first slide. We're going to talk about that
Okay.
IIH. It was the one where there we go, perfect. So this is a 32-year-old female, African-American female. I saw mid-April, and basically she comes in with complaints of blurred vision, some starbursts around headlights, some headaches. Felt like her words were jumbling whenever she was reading, and difficulty driving at night. She was a little heavier than normal as well. So first thing I did, we checked her VAs without her vision, without glasses. Actually, she didn't have any glasses at all, so we just checked her vision. She was about 20/30 individually, and of course, we want that to be as close to 20/20 as possible, right? And so then I went and pulled, actually did a refraction, kind of see what her prescription is, and initially, she wasn't seeing any better than 20/30, even with the slight prescription. It's a very slight prescription, but I'm like, hey, she's still young. Maybe she's having a problem, some over focusing during this exam. Let's go ahead and dilate her. Send her away for about 45 minutes because that's how long it takes for that person to dilate, for that drop to work. Bring her back. I had my my tech, our receptionist, not receptionist, my nurse, get another auto-refractor on her to kind of see what the estimate of her prescription was. Pulled that, wasn't getting much difference. Flipped some lenses, still wasn't seeing much better than what was before. If you look on the picture here, manifest refraction, that means what we get before we did before we dilated her. Cyclopedic was after, and as you can see, not much of a change in those numbers, right? So, but everything else was normal. Pupils were normal, all that stuff, right? So then what we did, she's already dilated. Let me look at the back of the eye. Ideally, I wish I would have done this first, especially with the complaints of headaches, but it wasn't like her headaches were like, oh man, they're terrible. It was just, she had some headaches. So I'm thinking she's a little farsighted. So once I look back there, we see the next picture, which is the, should come up.
Just want us to put the next one up.
It'll just say idiopathic intracranial hypertension. Okay, yeah, these aren't her pictures, but basically we'll just go with this. But if you look very closely, there we go. So it's kind of hard to see, but this, if you look at the optic nerve, so this is the optic nerve, some of her lids got in the way, but we don't want it to look like that. It looks very pale. It doesn't look like it's supposed to. It doesn't look good. Okay, then we'll go to the next picture. And so it's elevated basically, right? And I wish I had a picture that can show you what a normal optic nerve looks like. I may not have sent that over, so my apologies. I would encourage each patient to kind of Google a normal optic nerve so you can see what it looks like. And then we're going to compare the difference. The next slide. Okay, perfect. So, and I touched on this earlier, so this is just a brief review. If you look at the patient with IIH, idiopathic intracranial hypertension, again, that patient, there's no mass, there's no tumor that's pressing against the optic nerve. Normal to have a normal MRI on brain imaging. The cerebrospinal fluid will be normal. It'll just be elevated. It's just the composition of it, the proteins that's composes that makes it is normal. But person that has true papilledema, that's where they have a mass, something going on. Their MRI will show signs of something, and then they'll have abnormal cerebrospinal fluid composition. But in both of these, you will have an elevated, so you will have elevation on that as well. So that's the main difference between those two. We can go to the next slide. We'll wrap up with a brief review of IIH. Okay, so IH, again, it's increased intracranial pressure. It is without a detectable cause, mainly young to middle-aged women. It's also known as pseudotumor cerebri. We see it a lot in patients that are a little bit heavier, and I researched why, and because a lot of times women have a lot of tissue, our fat or adipose or more fatty tissue around certain areas. And so therefore that could be a reason why they're also more at risk. This patient, headaches, they can have some visual loss, kind of going in and out. They'll feel again to the side, the tinnitus, where it feels like there's ringing in their ears. And then they'll get some diplopia, but diplopia means the double vision. That's all that means, especially with light, which, my patient complained of light, especially driving. So one of the first things I want to do is treatment is going to be weight loss. They say, if we can get that weight loss down, a good 10 to 15%, great, right? And then they'll also put them on a pill. So my patient, whenever she went and they did the MRI, they put her on acetazolamide, which is a pill that's going to help relieve some of that cerebrospinal fluid pressure, right? They might also put them on topiramate. Topiramate is used to treat certain seizures and migraines, so they'll put you on that. And then, like I said, my patient, they did a lumbar puncture, and that's how they determined that, okay, this was IIH for sure, okay? So then, they sent me a report. I asked my patient for the report. They sent me the report, and then I patted myself on the back a little bit, just realizing I had the right diagnosis. And I would have done also, and I possibly would have done an optic OCT. Our OCT was broken, basically, during that period. And so I wasn't able to do that scan. But looking at the back of the nerve, I knew that it looked elevated. So, and then my patient, like I had said before, one thing they noticed that she was on for a bipolar medication. And so they took her off of that, had her discontinue that. And the last that I've checked up, she was still seeing a neurologist. She's still been on the acetazolamide. Like I said, you could be on that for months. It could be from 3 to 6 or 6 to 12, depending on the severity of it. And then also if she loses the weight and then it comes back, then, the weight she starts getting the weight again, that can also, cause this to happen again. So there are patients that this can reoccur in, for years. But yeah, that's the patient, and I hope you guys were able to learn a little bit tonight.
Yes, sir. You gave us a great 10 out of 10 presentation, my man. That was amazing, and we are so thankful that you could share with us on this webinar here under that topic. My head hurts. I'm sure the audience took away a lot of golden nuggets there, and just to understand the connection your optometrist, has when it comes to your health, not just your eye health, but your overall health there as well. So as I always say on every webinar, get your eyes examined. Don't delay. Do it today. Call your local optometrist. Get on their schedule. Make sure that you get your eyes examined there. We want to help preserve your vision. We want to protect your vision. And that is why we continue to do these great webinars. Every third Monday at 7 o'clock, we have awesome guest speakers on, like Dr. Adams, getting a round of applause. Y'all showing some love down in the comment section there. He did a fantastic job presenting on this topic here and sharing this information with the public. And we thank you, Dr. Adams. As we wrap up the session, if you may have some parting words that you would like to leave for the audience there, some words of inspiration, words about how they can follow you, come and see you. If they want to get your eyes examined, the floor is yours, and then I'll close out the show, okay?
Sounds good. Yeah, I work for my eye doctor now. I spent the 7 years part of a vision source, 6 years, man. Can't believe I've been out 7 years. But my eye doctor's corporate, so you can find us, pretty much anywhere. But get your eyes checked. That's the most important thing. Get them checked yearly, every year. And with school coming up, make sure you're getting your kids' eyes checked as well. A lot of places, it's never too young to have an eye exam. That's what I will always say. When I was in my old practice, I saw patients that were age of 2, and and don't ignore certain signs, right? The headaches, the stumbling, the falling, the feeling like I started wearing glasses when I was in kindergarten, and my teacher thought I was daydreaming in class. No, I just couldn't see the board, and I was very, very nearsighted. So I had a very, very strong prescription before I had surgery. So I would say do that, and you can follow me on Facebook, Britton Adams, our social media, EyeCareB, EYECARE, letter B. I know it's kind of cheesy there. That's Instagram. And then I want to just wrap up with one thing. I want to ask your opinion on this too, Dr. Brown, because, a a lot of times as patients, you hear the term blue light blocking lenses, right? How I put this nicely, for some patients, they feel it works, and that's great. Sometimes that could be a little placebo effect or feeling that. I'm not saying that's always the case, but as far as I am aware of, and I don't know if you've heard anything different, there's really no study that shows that they do actually help. Now, if you're at the computer, there are certain things like glare that they may help out with that, or certain like contrast sensitivity. But like, and from what I've read too, the main thing that they seem to help out with is like, you know, at night, whenever we're on our phones. Although a lot of our phones already go to that dim light setting anyway, but there are some studies that have shown that it really helped. But as far as like treating the overall, what I would say is don't just go buy some blue light blocking glasses online and think that's going to solve all your problems, right? You need your eyes checked, because if there is actually a prescription issue, yeah. So go ahead. What is your?
I mean, you hit the nail on the head. Don't neglect going in to see a professional. Go in to see your optometrist. Get your eyes checked by an optometrist. You know, don't try to self-diagnose or just look for a temporary fix or think that you have the magic bullet. You want to know for sure when it comes to your vision, your eyes, your health, that you're on the right pathway. And the best way to get that information accurately is to see a professional, which is your local optometrist, your eye doctor there. I agree with you, Dr. Adams. You know, some things out there are for marketing and sales, you know, so seeing your optometrist, we are trusted individuals. We are leaders in the community, and we're going to direct you in the best pathway when it comes to what's best for you as a patient there, and not so much seeing you with a dollar sign on top of your head. So you have to be careful. A lot of commercials are out there. A lot of things are out there to get your money easily out of your pocket, or to help you feel good sliding that card through to make that transaction. But we want to make sure that you're making these decisions based on studies, based on what's going to be helpful for you as our patients as well.
Yes, sir.
So thank you for bringing that forward there. It's very important. We will continue to have great webinars like this. Dr. Adams, a big thanks and a big shout out to you from the NOA, from the NOF, and from the NOSA. We thank you for being on here with us tonight, and we hope that you have a great rest of the evening there as well.
You as well. Thank you, guys. Thanks for having me. Be blessed.
Thank you. All right. And there you go, folks. Another great episode here on Protecting the Vision, talking about My Head Hurts, presented by Dr. Britton Adams. He did a fantastic job, left a lot of great information. My only advice and suggestion is don't keep this all to yourself. These webinars are on our YouTube channel, and you can go on our YouTube channel and see all of the previous webinars that we've done. Share it with family and friends, your colleagues there, so they can get this great information as well. We have a website, nationaloptometricfoundation.com. You can go and find out more about us and what we do, photos online, find out who our board members are, and then also on Facebook. If you'll go and like our Facebook page, we'll have information posted on our Facebook page as well. And to continue to do the great things that we do supporting the NOA, we have a Cash App, $ Protecting the Vision, that you can go and donate tonight. We thank you in advance. We thank our sponsors. We thank our partners. We thank you, VSP, for partnering with us here at the convention in Columbus, Ohio. A lot of great work there. I do want to share in Columbus, Ohio, I was awarded the Dr. Paula Boone Community Service Award. It was a surprise, total surprise. Dr. Boone is a great doctor, and to have this award now here in my home name and on her behalf there, and for the NOA, NOF to think that I was worthy of getting this award. Thank you so much. I appreciate it. We had a fabulous time at our convention in Columbus, Ohio. And as I said before, 2026 will be in St. Louis. Again, thank you guys for tuning in on this great webinar. We hope to see you there. The NOF is a nonprofit organization. We're always looking for that extra help. So if you want to become a part of us, you want to be a board member, send me a message in the comment section, and I'll be sure to reach out to you as well. And we'll see you on our next webinar. Have a great evening, everyone.